So good morning. Let's go ahead and get started. So it's my pleasure to grand rounds this morning. I'm going to talk about firearm injury prevention from the vantage point of the American College of Surgeons Committee on Trauma. I wear a number of different hats, but one of those hats is the chair of the American College of Surgeons Committee on Trauma, which the COT is the one of the two oldest freestanding committees of the American College of Surgeons. The American College of Surgeons has about 80,000 members, fellows worldwide. And the COT itself, the National Committee, has only 95 members, but has about 250 to 300 state and regional chapters, and about 3,500 worldwide. The COT runs ATLS, the Trauma Center Verification Program for the American College of Surgeons, and probably 40 other programs. This is not all my work. This is the Committee on Trauma's work. This is Deb Kuhl's, but the COT Executive Committee and the Board of Regents and young people in the American College of Surgeons, the resident and associate society, and the COT members themselves. It's a group of multidisciplinary surgeons. These are just a handful of people who've played key roles in this program. I think this is a good topic for grand rounds. If you sort of look at the United States in context right now, we really have some tough decisions. Are we going to be able to deal with any difficult issues, or are we going to just polarize along political guidelines and fail to address problems that are quite relevant? So this is one such problem. The COT has in one form or another for 3 decades has advocated for a reduction in the numbers of firearm injuries, but in most situations that's gotten caught up in politics. So we all have our own personal philosophy. This is a quote from John Bowman, Dr. Bowman, in 1916, 3 years after the founding of the American College of Surgeons. I'll let you read it and then I'll paraphrase it. So Dr. Bowman here makes the point that we all have our own personal philosophy, and to me what he's really saying is philosophy really matters. And then he talks about that we have a choice. We have you can have a good philosophy or an indifferent philosophy or bad philosophy, but I have to choose. And then how will I do it, and what will be my goals? And then what are the qualities of that equation, and how does it relate to patient care? So how has the COT approached this philosophically from a big picture point of view? Well, first, for 2.5 years, we've been very diligent about approaching the problem as a trauma system medical problem, not as a political problem, but as simply a medical problem, as we would approach any other medical problem. The second thing is we have a network of, it's now about 486 trauma centers that we can actually implement things. If we decide to implement something, we can actually implement it next month. We can implement programs through our network of trauma centers that are all across the United States, and will, I believe, within the next 5 years, will be across the globe. And the third thing is, as a group, we committed ourselves to provide a forum for civil, collegial, professional dialogue centered on what's the right thing to do for our patients and reducing the number of firearm injuries and deaths. I want you to look to your right, and I want you to look to your left. I'm going to show you data, but I want you to look to your right, and I want you to look to your left. And I'm going to tell you there's a pretty high probability that you will not agree with the person sitting next to you about the general benefit of firearms and freedom. However, I also want you to know that you will likely agree on what are some potential solutions or policy things that could be done to reduce the number of firearm injuries. So how do I know that? Well, we surveyed all the COT members. I'm going to show you the data from that survey. We hosted a town hall, an in-the-room meeting for all 250 or 300 COT members, where they're sitting in a room like this, and we had a discussion for 2 hours. And I will just say, I'll tip my punchline, but I will just say that was a model of civility and professionalism. It was a model. There was no long line at the mic. It was a model of civility. So we have consciously, actively avoided discussing this issue in forums or outlets that actually want conflict and polarization. And then we've committed ourselves to meet with stakeholder groups, all stakeholder groups, not just some stakeholder groups, but all stakeholder groups, to encourage a dialogue. That's been our philosophy. So on the surface, I'm a pretty simple person. On the surface, this issue doesn't seem so complicated. But when you really talk to people, and I would say this is probably a true statement, what I'm going to say, is that I've had the opportunity to talk to more people medically on both sides of this issue than probably anyone in the United States. And when you really get to the issue, it's really about freedom and the benefit of firearms. And all Americans, or almost all Americans, hold personal liberty very dearly. And there's really two contrasting stories about firearms, two contrasting narratives. The first narrative is that firearms are important for freedom and personal safety. And the second narrative is that the large number of firearms limits personal freedom and safety and create violence. In many ways, if you look at the people who strongly adhere to both of these narratives on the far ends of each narrative, you can almost substitute in the first narrative the word freedom for gun, so that gun control translates into freedom control. And the people in the second narrative who hold on to that very tightly, basically you could substitute gun and violence. And so synonymously you could simply substitute in their mind violence, so gun control is not controversial, that's violence control. The real issue is not whether we can focus on reducing the number of injuries. The real controversy is over the stories that we develop and we hold with respect to how we view firearms. So the other side of freedom, though, is responsibility. Sustainable freedom requires responsibility. And I believe this project that we've done aligns perfectly with the highest traditions of the American College of Surgeons with respect to responsibility. And really, my mantra has been freedom with responsibility. It's not my narrative. Viktor Frankl, who was a psychiatrist and who was captured by the Nazis and incarcerated in multiple prison camps, basically articulates that freedom is part of the story, responsibility is the other part. And actually, Dr. Frankl, who after the war wrote multiple books, said about the United States is that we have the Statue of Liberty on the East Coast, we need the Statue of Responsibility on the West Coast. That we need a statue of responsibility with a statue of freedom. So concerning facts and stories, this is from Jim Detmer. We heard about Jim Detmer from a speaker about a month ago. And here he's talking about facts and stories. And to give context to these quotes, he basically makes the point that these stories are important. It's not that me developing a story around what the facts are is called synthesis. It's my ability to understand the world around me. But really, a lot of times whenever I talk about the facts, I'm many times talking about the story that I've developed around those facts. And if we understand that that's my story and we choose to hold it a little bit lightly, then I can talk to you about your story and you can talk to me about my story. So I'm going to break this down in that setup: facts, stories, action. Facts. First I'm going to talk about the facts, then I'm going to talk about the stories. Particularly I'm going to talk about bridging the two stories, but first the facts. Barbara Gaines and Peter Burke presented this data at our town hall. And so what do we see at trauma centers in the U.S.? Well, these three mechanisms account for the great majority of all injuries: falls, motor vehicle crashes, traffic injuries, and firearms. And this is in order of prevalence in trauma centers. For those of you who know our trauma center well, you know this is not what we see. Or you know we see these three mechanisms, but we see motor vehicle crashes much more commonly than what this would lead you to believe. But when you look at all trauma centers who submit data to the National Trauma Data Bank, that's level 1, 2, 3, and 4, this is what they see. So you can see that firearms are really a very small number of what trauma centers see. And you would think, if you're like me, you'd think we've made great progress. But who dies? Who dies? This is deaths per 100,000, all deaths, not just deaths in the hospital, but all deaths per 100,000. And you can see that amazingly, those three mechanisms, motor vehicles, firearms, and falls, all have roughly the same number of deaths, somewhere about 35,000 deaths per year. So how is this? Why is that so different than what trauma centers see? Well, it's because that in order of lethality, falls are less lethal than motor vehicle crashes, are less lethal than firearms. So what's happened over time? I didn't ask you to raise your hands, but I didn't ask you to raise your hands if you to get your feel with respect to whether we were more likely to be a victim of homicide today than whenever I graduated from college. Well, the answer is we're much less likely, on average, to be a victim of homicide today than in 1981. If you look, this is firearm injury deaths in the U.S., all intentions in the U.S., and this is homicide. This is suicide. You can see that's not true with respect to suicide. And these are all other mechanisms. You can see that you'll see that adults make up the disproportionate number of these injuries. So I'm going to break this out so you can actually see it. But you can see the two dominant mechanisms for death from firearms are suicides, which account for about 60% of the deaths, and homicides, which account for about 40% of the deaths. So looking at adults only, by intent, you have suicides, homicides, and unintentional injury death. That's what the picture looks like. What about kids? What about kids? Children, and here I broke children down to the ages 0 to 14. Most people would call those children. And homicide, Unintentional injury, you can see significant progress has been made, and suicide. And you can see that it's a little bit of a worrisome trend with respect to suicide in the past decade, that those numbers are substantially on the rise, 0 to 14, almost the same number as homicides. And then taking a really long view from 1950 forward, what does it look like, the trends with respect to firearms and motor vehicle crashes? And you can see that firearms have been relatively constant from the time of 66 to about 2000. There was a bit of an increase, but it's increased somewhat, but it's been relatively constant. But you can see over time, motor vehicle crashes have fallen significantly, so that motor vehicle crash, to me, I would interpreting the facts now that we've made more progress with respect to reducing motor vehicle deaths than firearm deaths. So we surveyed the COT. This started in 2015. We had a response rate of 93%. I jokingly say this is a testament to my mother, that she taught me the virtues of nagging. That I'm not nagging, but have you called your brother? It's difficult to get a 93% response rate on a survey, I can tell you, particularly of busy people. In all fairness, it also was not just nagging, although there was plenty of reminding, I will say. But it was also that people viewed this as an important issue. And we had a response from all 50 states. A little less than a third have a military service background. Most members of the COT are practicing trauma or acute care surgery, but you can see we have a range of specialists as well. Almost all are at level 1 or level 2 trauma centers, hardly any level 3 or level 4s. There's a range with respect to firearm use. 20% never use a firearm, 7% use one weekly. So about 20% use a firearm once a month, and 20% never have. There's a group in the middle. We didn't expect this. There's many things I did expect in the survey, but if you look, a third of surgeon members of the COT have a personal experience with a family or friend being killed or injured by a gun. Didn't expect that. And initially we thought this was, this is our third who are military. They know people in the military who've been killed or injured. No, that wasn't the case. It was the same, both groups. For COT members, about 43% have a firearm in their home. The mean number is 8. You can see that a third have a magazine-fed semi-automatic weapon in their home. 7% have an NFA Class 2 firearm, which requires a special permit. That's a fully automatic weapon. And about half have a concealed carry permit, and about half of those carry routinely. These are surgeons. I told you that already. Why do those surgeons have firearms? 71% for target shooting, 2/3 for self-defense, half for hunting, and 11% are competitive shooters. So looking at the results of the survey, Steb Cools again. First, one of the first questions we asked was, because this is a real question, what priority should the American College of Surgeons give to reducing firearm injuries? 88% indicated it should be the highest level priority for the American College of Surgeons. 36% said it should be the highest, and 50% said it should be a high priority. Remember I talked about freedom being the real issue? We asked one composite question to try to get a feel for that. It sort of forced people into some groups, but this way we could tell sort of how they felt. So we asked a question about, are firearms beneficial, and are they a critical liberty or right? Are they generally beneficial and important liberty? And you can see that a little over half feel that firearms are either very beneficial and a critical liberty or right, or generally beneficial and important liberty. whereas 30%, about 30%, feel they're generally harmful, limit liberty, or very harmful and critically limit liberty, and about 17% don't have a strong opinion either way. So you can see that the committee members are relatively polar with respect to this, relatively polar. Then getting into questions in the survey, 95% of COT members felt that healthcare that it is also a right of healthcare professionals to be able to counsel patients about firearm safety. 96% said that the traditional funders for research should actively fund research on firearm injury prevention. Then we asked 15 policy questions. I'm going to quickly go through these. We don't have a long time to go through them, but I'm going to summarize them. And if you look, this is all COT members, these who have no firearm in their home. Yes, they have a home firearm. No military. Yes, military, male and female. And you can see that more than 90% of COT members agree that improving mental health screening, identifying and implementing evidence-based violence prevention programs, mandatory prosecution of convicted felons who are attempting to illegally purchase a firearm or body armor, increasing penalties for those who provide firearms to others illegally, preventing people with mental health illness from purchasing. You start to see some differences, but still, even differences between those without a firearm in their home, still very high percentages of both feel that these are policies that could be supported. Still at 90% overall COT members, so 7 of the 15, more than 90% of COT members supported making funds available for research, preserving the right of healthcare members to counsel, background checks, preventing people who are on the U.S. no-fly list from purchasing firearms, requiring safety features such as child-proof locks and smart gun technology. You start to see more differences between the subset analyses, but still more than 80% supporting these initiatives. Then getting to less support, limiting civilian access to ammunition designed for military or law enforcement. You can see that there's a pretty strong divergence between those with no firearm in their home and those with a firearm in their home and those with previous military service. Encouraging development use of technology that identifies the ammunition purchaser. This would be one way to track injuries. Not much consensus with respect to that. And creating a federal database to track firearm sales, divergent as well. And restricting civilian access to magazine-fed semi-automatic weapons such as the AR-15, 90% versus 44% for those with firearms in their home, and differences across the board between military service, men and women. So less consensus there, and the least support was requiring firearm owners to be 21 years of age or older. Not a lot of support for that. So summarizing, both narratives are present in the COT from a philosophical point of view. There's no clear agreement on benefit in firearms. Slight majority favor benefit and freedom. But there is a strong agreement on, one, the desire to move forward, and many policy choices. Many policy choices they agree with. There's definitely room for a strong consensus on what the COT members could agree upon. Then we ask the question, are these results generalizable? And I'm not going to show you all the data. It'll be out in the bulletin of the American College of Surgeons next month. But are these results generalizable? So the governors, the American College of Surgeons Board of Governors, which is a group that's elected or appointed from across the U.S., not trauma related, across the whole American College of Surgeons, opted to survey their members. They do a yearly survey of their members, of the governors anyway, and so they added some of our questions into that. And you can see that the clinical practice is very different from the governors compared to the COT. And I will say that, I'm not going to show you all the data, but I will say that there were extreme similarities between the survey results, that they were not identical. That the two areas where there was any substantial difference was about research and counseling. If you think about the beneficiaries of research would likely be the COT members, and counseling, those are people who likely would be involved in counseling, but otherwise the results were almost identical. Not identical, but almost identical. So we have a pretty big gorge, and the narratives that we create definitely create at least the perception of a chasm, that's difficult to cross. But this is the Zambezi Railway Bridge at Victoria Falls, circa 1905, and it is possible to build a bridge across the chasm. And actually, I believe that the technical skill, the will, the effort needed to build this bridge is actually less than us building a bridge across our colleagues. That it's a matter of whether we choose to build a bridge. And I believe we should choose to bridge that chasm. And how do we do that? How to do that? My grandmother could have told you all of this without a slide. That fostering how to bridge the chasm is fostering and encouraging dialogue between both people with both narratives, centering around reducing injuries, this is the best for a patient, without limiting personal freedom of legitimate, responsible gun owners. It's the best for a large number of surgeons, definitely best for 53% of our COT members. And then focus on being professional, kindness, especially when it's difficult to do so, civility, I'm going to talk a little about civility, respect for opposing views, particularly minority views, tolerance, and committing ourselves to, if you really want the ultimate, it's not taking a vote, it's not going with what the majority says, it's saying we're going to talk about this and look for win-win, and if we can't get to a win-win solution, we have no deal. P.M. Forney wrote a great book, 2010. I highly recommend it. It's very short. And he basically points out that there's two ways that that I can show disrespect for you. One is by telling you that your opinion is stupid, worthless, and ridiculous. Surgeons are not immune from that style. But the other is by simply assuming that you must think the way I think. You have to think the way I think. So he basically says that I should expect that you can look at the world differently in the way you look at the world, and I should realize that, and that then we can actually have a respectful discussion with each other. The COT, in my opinion, gets us A+ for this. I will say that town hall was a modicum, was the ideal of professionalism. Back to our facts and stories. And so from an implementation standpoint at the American College of Surgeons, we've been working at the base of Lencioni's pyramid here, which is building trust. Once you can build trust, you can get by the fear of conflict. We're actually at a point inside the Committee on Trauma where we can actually realize we don't agree on all these things, but there's things we can agree upon. Then you can get to common commitment, accountability, and results. This is generalizable to things other than firearm injury prevention. So, how to move to action? Well, Barbara Barlow, for her Injury-Free Coalition for Kids, basically her approach, A, B, C, D, E, analyze the data, build community coalitions, communicate the problem, develop interventions, and evaluate the results. So we know this, that the trauma system people know this, the injury prevention people know what I just told you. They inherently know that if I want to do a bicycle helmet campaign in a neighborhood, and the neighborhood doesn't agree with me, well, they know how to do that. If I put on my white coat and posture and get all arrogant and old school surgery, they're not going to listen to me. However, if I respect the community, if I engage the community, if I look for partnerships, if we start with a kind and empathetic discussion versus a dogmatic and patronizing discussion and dialogue, then we can actually make some headway. Plus, this is a complex problem, and we should address a complex problem as a complex problem. You don't address a complex problem as a simplified problem. In the United States today, we have a need and a desire to boil everything down into a 140-character tweet. You cannot solve this problem with a series of 140-character tweets. And this is a long-standing problem, and we need to think about it in the long term, both short and long term. I talked about this town hall. I'm not going to go over it again. So we're looking to move forward where we agree, recognize where we don't agree, and work towards creative solutions and consensus where we don't agree, focusing on reducing injuries and deaths from firearm injuries. We published a couple of articles on this in the Journal of Trauma. We've presented at the American Association for Surgery of Trauma last year. I talked to you about the survey of the governors. The international surgeons want to survey themselves, the international portion of the COT. The AAST, the American Association for Surgery of Trauma, agreed at this meeting last week, in their meeting last week, that they want to survey themselves. They want to survey themselves because the COT is older, more senior. They want to see how a relatively younger, more academic group of surgeons look at it. We've published an editorial in the Annals of Surgery. We're working with ACS advocacy teams for things where we agree upon. And we have a whole team of people looking at evidence-based violence prevention, not focused on firearms, but what could we do in trauma centers that would reduce violence, interpersonal violence and personal violence to oneself, not just something that would reduce the violence. That was one of the things that came out of the town hall. It was a very interesting discussion about the town hall. Is at the root of homicide, whether it's firearm or non-firearm homicide, is violence. And we have a culture of violence. People make a lot of money on that culture. And how do you address that? How do you make a dent in that? We have a mental health problem. But in the town hall, it became clear. So we have mental health treatment. We focus on mental health treatment and access to mental health. But if you think about it from a public health point of view, there's the issue of mental health treatment, but also mental health hygiene. How do you have improved mental health hygiene in a population? Well, around this, you make a culture of hope versus a culture of hopelessness. So we're also meeting with the full spectrum of stakeholder groups. I've personally met with the Brady campaign. I've personally met with the NRA leadership. I've personally met with every town. And we're looking to engage trauma centers across the globe. There are noteworthy violence prevention programs that will also be in the bulletin. There's a whole handful of them, of communities who've actually really looked at what can you do that would reduce violence in a community. So wrapping up for this complex problem, from the COT point of view, there's definitely a desire to move forward to reduce the number of injuries. There's room to agree upon for what we want to do with respect to policy. The members of the COT don't all agree on benefit and freedom of firearms, but they're working for constructive solutions. Thank you very much. Happy to answer any questions. Dr. Abergili.
In Japan, they abolished the use of arms. It used to be the highest country where there was death from killing. And since mortality dropped to zero, it became the most pacific country on the earth. What do you think about this?
I don't know the data on where they were the most violent before, but I do know that from personal discussions with a fellow over a 2-year period of time, that they have a very low penetrating trauma, firearm injury, death rate. The only way that the only way that could ever happen in the United States is with the effective consent and the leadership of responsible firearm owners themselves. Will not happen by a decree. And so, to me, and I've been, I mean, I'll speak a little bit more plain spoken than what I might speak nationally, but to me, the community of interest, the community that can really make a difference, is the responsible firearm owners in the United States. That is the group that, these are my friends. I have many friends. So I doubt we're going to get to what you would say with respect to Japan, but we should at least be opening to look around the world and look and see, well, gosh, what happened here? What happened here? What could we do that would meet those goals that I'd said, which is reduce the number of firearm injuries and preserve or enhance the freedom of people who own firearms in the U.S.
How do responsible gun owners, like Dr. Myers and myself, address violence in like Chicago, where most of the homicides come from, places like that?
Well, you don't have to. You don't have to. You don't. There's a group of people who can do that. So it's not dependent upon you to do that. I think there are. The first thing is to recognize 60% of the deaths are from people killing themselves with their own gun. It's an important issue to. I don't want to speak for the other group, but I'll say at least one of the stakeholder groups we talked to was an important issue for them. I think some of the things would be to look at how do firearms get from the hands of legitimate owners into pawn shops in areas where there's really high violence and get in the hands of people who do that. You should ask the question, how does that happen? So I don't think you can, and I don't think there's a group of people who will take that up. The people who will take that up are people who are in those communities, in those trauma centers, in those communities who will want to address those things. So I don't think you have to do that. To me, and I'm going to use the automobile analogy, I'm going to answer it a little different. I'm going to answer a different question than what you asked, is to me, I think you could, and I'm not saying you should, but I think you could advocate for making firearm ownership safer. For making firearm ownership safer. That's the whole thing that's happened with motor vehicles. Motor vehicles in 50 years have become progressively safer and safer. Probably owning a car is not the safest thing for me. I mean, probably if I didn't own a car and I just walked back and forth to my house, in fact, I think the data would support that. If you look, for example, in Hawaii and New York City, actually there's a lot less vehicular trauma than in Houston, Texas. But we've advocated for making automobiles safer and safer and safer. That I think would be a good goal, but not I'm not telling you that's what you should do, but I think that's one of the things that could be done. And I'll just say now I'm going to say speak for myself, not for the COT, but one of the things that I've advocated for with Dr. Oust, actually 15, 20 years ago, arguing in the operating room at 2 a.m., I said, why aren't you supportive of making a firearm that could only be fired by its owner? I need my gun. It's like, okay, I know you need it, but this little device I have, well, it's over there. It knows its location in space and time, and it's pretty good about actually being only opened by me if I chose it to happen. That is a goal that could be done, but that will never happen unless there's a market for it. Dr. Myers.
So, I think great talk. I think you put the data in really well. I think there's a lot deeper diving that probably needs to go into that. But
Yep.
My question I have is, why is the COT picking this as a focus topic when its origin and the problems from it aren't really in our spectrum of care? This is mental health. The suicides, the homicides, childhood suicides. This all, the root of it is mental health, and it's not even in our realm of, you know, of a scalpel or counseling.
The same reason, but go ahead.
So, and the question I have about the suicides, what are suicides nationwide from all causes? What do those numbers look like over that same time period?
The first, why? Well, because it takes 35,000 people's lives, and it's a problem that we manage, and we are the primary managers of that problem. The same reasons why we would address seatbelts, and the same reason we would deal with child occupant safety, the same reasons why we would deal with drinking and driving. That's the reason why. And we're not more or less committed to this than those other causes, but we think we should not shy away from addressing something that kills about the same number of people as motor vehicle crashes, and we should look at that as a complex problem. And I think we've been very consistent with respect to that. We've got personal statements on, position statements on all things related to motor vehicle crash deaths, other than just how do we operate and do angioembolization from a spleen. So this is very consistent with that. It's also consistent with developing programs at local trauma systems, like, as you know extremely well, and you know it's difficult to implement, but the screening and brief intervention for alcohol for people who come into a trauma center. So that's the reason why. The second is what's suicide. Well, I don't have the data on it, but I will tell you what Western European data would show. There is a lot of non-firearm suicides in Western European countries. But I do not hold on to the argument that just because there's other ways to kill yourself, we shouldn't look at ways that would be commonsensical and that might be palatable and attractive to firearm owners that might reduce suicide deaths. Alicia.
I've been interested in addressing the reason why the uptake's been pretty significant since about 2005. I personally think a lot of it has to do with social media, and anybody knows me knows I hate it, and I don't go on Twitter, but nevertheless, I do think those things are a venue for young people, or people of all ages for that matter, to be peripherally very nasty, and it ironically at the same time can be socially isolating for a lot of people. Is there any interest in addressing how that can potentially have impacts on their mental health and ultimately suicide?
Definitely people working on it. There's actually some quite proactive suicide prevention groups who they'll definitely talk about social media, its role. There's other factors as well. And the COT's role is not to do all those things, but to actually advocate for partner organizations who are working on reducing suicide violence. And yeah, it's complicated, but I'm sure those factors do play a role. Yes, sir.
Do we know how often alcohol is involved in these firearms?
Yeah, it's probably at least 50%, both on the homicide and the suicide. So there's no question that, and I think it's a very good point you bring up. And it's not a point we've discussed a lot on the Committee on Trauma, I will say, although we do have a whole bunch of things with both alcohol and other substances. That we talk about it's about a third of motor vehicle crash deaths after 2 a.m. It's like upwards of 60, 70%, but of motor vehicle crash injuries and deaths are alcohol related. It's probably higher for both you shooting me shooting you, so interpersonal violence, and me shooting myself. There's a alcohol problem at close to the root with respect to that. Dr. Peterson.
Dr. Stewart, great talk. You probably can ferret out the data in there. Is there a way to determine the firearm deaths as compared, as responsible from someone who was a gun owner versus an unregistered weapon?
An illegitimate gun owner?
Yeah, right. I guess so. In terms of maybe the gun is registered, but it's not in the hands of a legitimate owner. So in terms of the safety, I heard you say responsible for gun owners. So is there a way to pick that out of that data?
There is. I'm not an expert on it, but probably most of the suicides are from legitimate gun, what I would call legitimate gun owners. Probably a high percentage of the homicides are from illegitimate gun owners.
In your statistical analysis, and you're talking about areas where there are discrepancies between gun owners and non-gun owners, in a fair number of them, even both groups, the majority of both groups agreed. Whether it was
Correct.
52% versus 80%.
I think the majority agreed on everything. They didn't agree on everything, but a majority supported all of the policy.
And so, while there are some statistical p less than 0.05 differences between the groups, they really look like they're a consensus if the majority of both groups are in agreement. And so, I just wonder, is that how you're approaching it as a COT?
We're approaching it from a consensus point of view. So we could, I would say we're not. We are absolutely not. And I expect for you guys to defend me on this as well, my gun-owning friends, okay? We are not proceeding by simply saying a majority support all these things, so therefore we support all these things. That's not the way we're doing this. We're doing it the way I said in my slide, that we're looking for win-win solutions that people can, and here's what the COT can for sure support. Research, this is the way we would approach any problem we deal with. From a medical point of view, from the COT, we would say we support research to understand, to do the deep dive on the data, to really understand what the problem is, and to come up with interventions that work, not interventions that Ronnie makes up, in my garage that might work or may not work, but actually interventions that have been proven to work. So we support research for better understanding the problem. We support your ability to counsel people with respect to that. We also do believe, though, that counseling should be effective. If you're, for example, if you're a gun owner and I'm not a gun owner and I want to get all preachy with you and telling you what you should do, blah, 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 it's unlikely to change your behavior. In fact, it may make you more likely to do the opposite of what I'm saying. But the COT definitely supports the right of healthcare professionals to counsel. So we think we have a strong consensus on that, and there's about 5 other areas on there that we agree that there's a consensus, but we're moving forward along that in that way. Simply because if you said this is a majority, I mean, we know in the U.S. it's somewhere close to 50-50 divide. And if you want no progress, then just deal with it like that, because we won't make any progress.